Hello, I'm Dr. Jeffrey Weber. I'm a medical oncologist at the Laura and Isaac Perlmutter Cancer Center here in New York City. Today I'll be commenting on a couple of abstracts presented at the recent AACR meeting that was held in New Orleans, one of the first live meetings that we've had in quite a while. I'll describe two abstracts that I thought had some importance. One was a report on the SWOG 1616 trial, which was a trial of IPI with nivo at what we call standard doses versus IPI alone in patients with unresectable or metastatic melanoma that had not responded to anti-PD-1 therapy. And again, this is a big problem because the question for a lot of oncologists is, what do you do in the community when someone fails PD-1? How do you manage them? And this was a randomized phase 2 trial with an interesting 3-to-1 randomization. Total of 91 patients ultimately treated who either got ipilimumab at 3 per kilo alone, which is, I would say, a relatively standard dose, versus so-called standard dose ipi-nivo with ipi at 3 per kilo, nivo at 1 during the induction, followed by up to 2 years of nivolumab at 480 milligrams every 4 weeks intravenously. And the primary endpoint was progression-free survival, and those data suggest there was a modest increment in PFS, which I thought was a bit of a surprising endpoint for an IO agent, but nonetheless, 3 months median PFS for ipi-nivo versus 2.7, that's a very small difference. 6-month estimate 34 versus 13, which seems pretty different. Hazard ratio 0.63, p-value one-sided 0.037, so it looks like the combo was the winner, as we might expect. But again, if you look at the forest plot, it tended to favor the combo for virtually all of the parameters, except for, as you might expect, prior adjuvant therapy, which usually would have been with PD-1 blockade alone. And then if you look at the duration of response, interestingly, not reached with IPI, although small numbers of responders, but IPI-nivo 18 months, response rates were 28% for the combo versus only 9%, as you might expect for the IPI arm alone. Toxicity, as you would also expect, higher at something like 56%, grade 3-4 for the combo. And it was only 31%, a little higher, but not too far off from what you would expect with a reasonable dose of ipilimumab alone given to patients who had already been through therapy. And again, if you look at the waterfall plot, it clearly looks like you had many more responses with some CRs, actually. I think there was something like 6 CRs total in the folks who got the IPI plus nivo. However, at the end of the day, when you look at the survival, the curves started out looking better for the combo, but they cross over, and the medians were really not different. IPI actually 25.7, combo 21.7. The 12-month survival was a little better for the combo at 63 versus 57, but the hazard ratio for survival overall 0.93, and the p-value is 0.4, so no real difference. And again, some correlative marker studies showed that there were increases in CD8 T cells, but pretreatment CD8 T cells didn't help you. They were not predictive. And the investigators, and this was presented by Ari Vanderwald, conclude that ipi-nivo is inappropriate next-line therapy in those who have not responded to anti-PD-1 alone. And when Mario Schnoll discussed it, he did have some concerns over the durable PSF difference declining to less than 10% when you go much beyond a year. And the question arose, would a higher dose of IPI been any better? And the problem is the higher dose of IPI is clearly very toxic. Now, a second abstract, something completely different, tested yet another one of the intratumoral injectables with PD-1 blockade in those who were refractory to PD-1 blockade. This was the Spotlight 203 phase 2 study presented by Ivan Marquez Rodas from the Hospital Marañón in Madrid. And again, this is an interesting drug, which is a intratumoral injection. It's a nanoplex double-stranded RNA that activates TLR3, and it also activates other inflammatory genes like RIG3 and MDA5. It can theoretically improve antigen presentation, enhance T-cell infiltrate. And again, in the tumors that don't have a T-cell infiltrate, this might be very useful. And it had a first in human study in a small number of patients, I think less than 30 patients, where there was a 20% response rate. So this was an attempt in a slightly larger group of patients. to try to reproduce those numbers. And again, baseline characteristics this time included acral, lentiginous, and mucosal melanomas, in addition to patients with cutaneous melanoma. And in terms of safety and toxicity, the percent of patients with grade 3-4 side effects was relatively trivial. It was 5%. There were a total of 40 patients treated on this trial. So those are, I think, reliable numbers. Overall, I think that this was a very well-tolerated regimen. Best overall response rate was 25%, with actually a CR rate of 10%, which on the surface of it looks pretty encouraging. PR 15%, stable disease 40% at 24 weeks, so your disease control was 65%. When you look at duration of response, it's actually fairly favorable. For those who have non-cutaneous disease, it's not been reached. It's something like at 16 months, a 66% continuation of response. But when you look at the data closely, the vast majority of responses were in the injected lesions. The response rate was less than 10% in the non-injected lesions. I think there were 3 bona fide responders out of the 40 in the non-injected lesions. And to me, that's a really important piece of information. The other important data is if you look at the progression-free survival for the group actually it was 42 patients in the intent to treat analysis. The median was only 3.8 months, which is fairly modest. If you look at the median progression-free survival of the mucosal and acral patients, or those who had LDH more than 3 times upper limit of normal, it's actually pretty modest at 2.2 months, but not reached in those who have non-acral, non-mucosal melanoma with what we think are probably normal LDH rates. So again, the conclusion of the investigators is that the data warrant further investigation. I can't argue with a 25% response rate in PD-1 refractory patients, but again, the big issue is this really something that's going to be useful only for those where the injectable lesions are those that are predominant and those that you monitor, or will this really be effective for distant disease, which is the parameter that's going to affect survival in the real world? At any rate, this is Jeffrey Weber. Please feel free to call in with comments on these presentations and suggestions, and I thank you for your attention.